from Shankar Netralaya, Chennai, that where we have analyzed 277 children and their visual outcome, and we have realized that the 1/4 of these children were blind, at least in one eye, when they presented to us. And if you see the etiology of this blindness, and you can see here the 60% of them were suffering from anterior uveitis. So it is very understand that don't underestimate anterior uveitis. It can be a cause of blindness also. So very importantly, you have to differentiate. You have to do the JIA. I always tell ABC of diagnosing JIA. The juvenile idiopathic arthritis can be asymptomatic, though it is not mandatory, but most of them can show ANA positivity. It is bilateral, often associated with band-shaped keratopathy, and these are the notoriously the white eye uveitis, no congestion you will see, and the course is chronic anterior uveitis. Now, the second one, sometimes you see here the three slit lamp photograph I have shown. The first one is a 5-year-old male who presented with an anterior uveitis-like picture, but when we did a UBM, and we can see the seeding in the pars plana region. So it was basically a case of diffuse anterior infiltrating retinoblastoma, which presented like this. The second one, you can see the known patient of ALL, and the patient was under remission, and when she presented like this, kind of hypopyon or the mass in anterior chamber, and it was basically the recurrence of this inflammation. So recurrence of the leukemia. So the third one, you see the 68-year-old female, and it was basically a case of intraocular lymphoma, and which presented like lymphocytic infiltration in the anterior chamber. So sometimes that muscularite syndrome can mimic anterior chamber. Now, coming to that anterior uveitis with hypopyon. Hypopyon is a dreaded sign, and it can be due to infection, and it can be due to inflammation also. Let's see the scenario here. The three scenario of that hypopyon can happen in a patient. Like in first patient, the patient can have anterior uveitis, severe fibrinous reaction, lower backache, and the recurrent attacks of uveitis. And if you do investigation, you may come across like this kind of picture where HLA-B27 is positive, and sacroiliac joint may show effusion. So it was a case of HLA-B27 associated uveitis. The second picture, it can be a panuveitis with mobile hypopyon, and if you take the history, patient can give you a history of recurrent oral and genital ulcer, and you further investigation, you can send the patient to a rheumatologist, and you can do HLA-B51, though it does not rule out or rule in the diagnosis of Behçet disease, but it can be a second picture. Let's see the third one. Now, third one can be another, again, case of panuveitis with hypopyon. There may be history of hospitalization or prolonged diabetes mellitus, and patient can give you a history of septic foci like a big abscess in the thigh. So this patient, if you send to a vitreoretinal surgeon for vitreous biopsy and start doing the blood and urine culture, so it can be a case of endogenous endophthalmitis, which can present as hypopyon also. So you have to know all the spectrum of this entire hypopyon manifestations. Now, coming to that another entity, I consider it as a red flag signs, because this is a 27-year-old male, known patient of HLA-B27 associated uveitis, history of recurrent attacks of inflammation, and the patient is steroid responder. Why I'm telling that this is a case of red flag signs? Because you need a different strategy to manage this case. Because the patient is steroid responder, you can't every time treat the patients with topical steroid, which will again cause the secondary glaucoma and other. So these are the patients you have to take care from the beginning. You need to start this patient on early immunosuppressive, so that the recurrence, you can bring down the recurrence, and you can actually reduce the inflammation or recurrence in these patients. Now, this is my last point, that anterior uveitis, you know that there are the diffuse scleritis are associated with 40% of systemic disease. It can be initial manifestation. And in cases with necrotizing scleritis, it can be as high as 95% of the systemic association also. So sometimes this anterior uveitis may be some scleral congestion, can be presenting sign of rheumatoid arthritis, granulomatous polyangiitis, relapsing polychondritis, and various other systemic diseases disease. So you need to start treatment very early stages, so that most of them can cause lethal vasculitis. So your primary aim will be not to save only the eye, but also the life of the patient. So if you can diagnose, decode this anterior uveitis with systemic manifestation, you can actually save the life of the patients. Thanks you. Thank you.
Okay, thanks very much, Partha. A terrific talk. We've got probably time for one question, if anyone has any. Yeah.
A very nice talk. I'm a rheumatologist. So I just wanted to know that we often get patients with, say, 2 episodes of uveitis in a year. So generally, we don't start these patients on methotrexate. But they are steroid responders. Some of the ophthalmologists give topical steroids and some give oral steroid depending on the severity. So in these cases, do you recommend that methotrexate should be started?
If the patient is steroid responder, I feel it is always better. But because you can't predict the recurrence rate here. No. So we are talking about steroid responder in ophthalmology. Abra is my rheumatology friend. So at steroid responder means that if 15% of our population, they respond to any form of steroid. The moment you give any form of steroid, there will be a hike in the intraocular pressure. Okay. So they develop glaucoma. We call it steroid response glaucoma. So we are talking about that thing.
Okay. Thank you, sir.
Okay, thanks very much, Partha. Oh, yeah, sorry.
What would be the best immunosuppressive you feel in children in any of these entities?
See, children, if you talk about this GIA group, no, I feel the adalimumab is nowadays best. But the problem here is many of our patients can't afford the cost. So the preferred, I think, Abra will be the best person. I think methotrexate is the...
Thank you.
Okay. Fantastic. So our next speaker is Dr. Jin Choi from Seoul in Korea, and she's going to talk about hypertensive anterior uveitis. Thank you.
Thank you, Chairman. I'm Jina Choi from the Catholic University of Korea. It is a great honor for me to speak today. Today I would like to talk about hypertensive anterior uveitis and current aspect. Among the various kinds of uveitis, glaucoma is most commonly complicated in the cases of anterior uveitis. In uveitic glaucoma, tissues other than optic nerve head and angles are affected, including vitreous, retina, iris, and cornea and epithelium and cornea endothelium, according to its etiology. Glaucoma in uveitis has a nature of episodic and partly iatrogenic nature, and it accompanies very high intraocular pressure. And in 20% of the clinic-based uveitic cases, and it deviates young and of working age and more rapid glaucoma progression than is seen in primary open-angle glaucoma. As you can see in this study using large-scale real-world data, which shows the visual field progression was greater in uveitic glaucoma compared to POH cases. There are many factors influencing intraocular pressure in uveitis, so it is very hard to understand the exact etiology of IOP elevation in these cases. But for the effective treatment, it is very important to understand the mechanism of IOP elevation in these patients. So there is some schematic of recommendation on the etiology of the IOP elevation based on the timing of IOP elevation and inflammation into 4 mechanisms. But in these patients, the aqueous humor outflow is significantly diminished. As you can see in this study, the recurrent anterior uveitis with glaucoma or ocular hypertension showed the lowest outflow facility. Let me show you 2 cases of uveitic glaucoma. First one is a 40-year-old female who had a history of HLA-B27 positive anterior uveitis, and she came to our clinic due to decreased visual acuity. In her slit lamp examination, she showed intensive anterior chamber inflammation. However, her intraocular pressure was 8, relatively low compared to the normal limits. So we started a steroid eye drop, and after the cessation of the inflammation, her IOP goes up into 16. The low IOP in this patient seems to be associated with reduction of aqueous outflow production, as well as profound increase in unconventional drainage. Let me show you another case of 41-year-old male who had visited our clinic for the management of episodic IOP elevation. He had a first attack of uveitis in 1989, and he had recurrences of 1 to 2 times per year. At the time of recurrence, he had been treated by conventional treatments such as steroid and anti-glaucoma eye drop. When he visited our clinic, he showed high intraocular pressure of 30, and he showed some keratic precipitate on his cornea endothelium, but anterior chamber inflammation was very minimal. But he has no glaucomatous damage or no corneal endothelial cell damage at this time. But after that, we had been followed him about 20 years, and he showed the recurrence, increasing recurrence of the attack, and he showed also the decrease in corneal endothelial cell count. So in 2022, we performed the aqueous humor analysis, PCR analysis, and he showed cytomegalovirus positive results. After the initiation of antiviral agent, his recurrence has been diminished. However, at the last examination, he showed about the half of corneal endothelial cell count compared to the baseline examination. In this case, the IOP elevation is related to trabeculitis, and in these days, it is supposed that the major cause of this kind of IOP elevation is related to infection, particularly virus infections such as HSV1 and cytomegalovirus and toxoplasmosis et al. Sun Working Group had summarized the key findings of this viral anterior uveitis. This is HSV1 uveitis and varicella zoster, and finally cytomegalovirus. Although they did not specify any representative clinical finding, it is known that the coin-shaped lesion, as you can see here, it is the key finding of CMV anterior uveitis. When I summarize the key findings of Sun Working Group reports, the prevalence of high intraocular pressure, ocular hypertension was seen in the cytomegalovirus in 50% of the cases, followed by HSV1 and varicella zoster and sarcoidosis. It is not surprising that infection causes 50% of the uveitis cases, and it is related to the fact that anterior chamber has immune privilege, such like the testis or CNS. In this IOP elevation, the direct inflammation of the trabecular meshwork cells is very important because it has a key role in regulation of intraocular pressure. Our group had infected these viruses in the human trabecular meshwork cell, and we could find that the cytomegalovirus is very permissive in TM cells compared to the control cells, as well. And in addition, HSV1 was also very permissive. And we could find that the virus induced contraction of the trabecular meshwork cells, including the cytoskeletal changes, which collectively increased the intraocular pressure. I had the opportunity to have a visiting scholarship in Duke Eye Center, working in Dr. Basanta Rao's lab, and we studied the proteomic analysis of aqueous humor derived from cytomegalovirus-associated hypertensive anterior uveitis, and we could find that 50 proteins were significantly elevated. And we could find that the top significant overrepresented pathway includes complement activation and humoral immune response. We could summarize the proposed IOP elevation mechanism in virus-induced hypertensive anterior uveitis. First is the host immunity, and the second is virus-induced direct changes. And we could study the two more factors. First one is the role of TGF-beta in these cases. In Singapore group, they reported that in Posner-Schlossman syndrome had a significantly elevated TGF-beta 2 level compared to the cataract controls. Actually, TGF-beta is very important in the pathogenesis of glaucoma. TGF-beta 2 has been known to be elevated in primary open-angle glaucoma and TGF-beta 1 in pseudoexfoliation glaucoma. And also it is elevated in patients with failure of glaucoma filtration surgery. we performed the engineered pathway analysis in the same sample, and we could find that the top upstream regulator in aqueous humor of CMV anterior uveitis was TGF-beta 1. When we infect the cytomegalovirus in human trabecular meshwork cells, we could find that increased level of TGF-beta 1 in cytomegalovirus-infected trabecular meshwork cells. So we performed the analysis of concentration of aqueous cytokines in these patients. This is the demographics. And we could find that a higher concentration in the aqueous TGF-beta 1 level in hypertensive anterior uveitis compared to the controls. And also in the patients with hypertensive anterior uveitis, those with glaucoma surgery had a higher level of TGF-beta 1, which shows TGF-beta is elevated and have a role in these patients. Finally, I would like to focus on the role of chemoattractant cytokines. Extensive literature has been suggested that these cytokines has been elevated in Posner-Schlossman syndrome and uveitic glaucoma. When we infect the HSV1 in trabecular meshwork cells, we could find that these chemokines had been elevated in the cells, recruiting neutrophil and macrophage respectively. When we applied these cytokines into the trabecular meshwork cells, we could find the significant increase in myosin light chain phosphorylation, which induces cytoskeletal contraction of the TM cells and finally increasing intraocular pressure. Let me summarize. The virus infection is the predominant cause of hypertensive anterior uveitis. Among these virus infection, cytomegalovirus is the major cause of intractable cases of hypertensive anterior uveitis, which is characterized by recurrent episode of elevated intraocular pressure and progressive loss of cornea endotheliums. Active viral infection in the TM cells could be the key mechanism underlying the IOP elevation in these cases. Other causes include TGF-beta signaling, increased chemokine, and also host immunity could play a role in the IOP elevation in these cases. Thank you for your attention.
Thank you so much, ma'am. It's an excellent presentation. Any questions from the floor, please? Thank you. We will take it up in the panel discussions again. May I invite our next speaker, Dr. Mayur Morekar, Childhood Uveitis, 5 Differences to Remember.
Good morning, everyone, and thanks for having me here. We have a rheumatologist in the audience, so this is going to be interesting. These are my teachers, and I always start with acknowledgements to them. And you'll notice here that the co-authors include a pediatrician, a pediatric ophthalmologist, and a pediatric rheumatologist. Coming to the introduction, childhood uveitis is a unique but common situation faced by a pediatric ophthalmologist and a uveitis specialist. It is unique because it involves certain important differences from uveitis in adulthood. So this is how generally childhood uveitis would present. That is the left eye of a 7-year-old girl with non-granulomatous anterior uveitis and band-shaped keratopathy with a mature cataract. You see there is no redness. It's a white eye. So coming to the first difference in presentation, in adults, uveitis is often accompanied with redness, pain, and watering and decrease of vision. But childhood uveitis, especially in GIA, is known to be silent, that is in a white eye, anterior and characterized by band-shaped keratopathy, posterior synechiae, and complicated cataracts. However, there is this other entity that is juvenile spondyloarthritis, and children with juvenile spondyloarthritis are found to have symptomatic anterior uveitis, with many patients having redness, pain, and light sensitivity. A slide or two on what is spondyloarthritis. We know it's a group of inflammatory arthritis affecting both children and adults, and it is characterized by the presence of enthesitis, a potential involvement of the spine and sacroiliac joint, a strong association with HLA-B27, and development of uveitis, which is more often acute onset and or symptomatic. But what's there over here is that the International League of Association of Rheumatology, that is ILAR, classification of JIA does not recognize a specific entity for juvenile SPA patients. So juvenile SPA patients are considered as a part of JIA. Juvenile SPA includes these 5 entities, that is enthesitis-related arthritis, juvenile psoriatic arthritis, undifferentiated arthritis, reactive arthritis, and the arthropathies associated with inflammatory bowel disease. Juvenile spondyloarthropathy-related arthritis can be difficult, like we encountered in this 13-year-old boy who was HLA-B27 positive, a very severe non-granulomatoous panuveitis. You can see there that we've used a lot of immunomodulation, including infliximab, adalimumab. A lot of challenges, especially when we were doing cataract surgery, we required iris hooks. There was a fibrinous anterior capsule. There was cyclitic membrane. The eye was almost pre-thesical, and we had to use the IOL on the sulcus. The surgery is done by a vitreoretinal surgeon using a posterior approach. Final best corrected visual acuity achieved here was finger counting 1 to 2 meters, and that's thanks to a rheumatologist who did a lot of immunomodulation for this patient. So coming to what are the gender and age characteristics of JSPA. JSPA is something that really entices me. Now herein there are 2 groups. The first group that conventionally presents in patients less than 4 to 5 years of age, and it is the one that's similar to oligoarticular or polyarticular JIA. It has a female preponderance, there is dactylitis, and there is a high incidence of ANA positivity and uveitis. And the second group that presents at a later stage, the predominant population is boys, and they have enthesitis, sacroiliitis, and psoriasis. So to say that in JSPA we have 2 groups, the first group which is the silent group, that is like JIA, and the other group which is like the adult group. Now the difference too, that is in relation to DMARDs. So in adult uveitis, initial attacks may be treated with topical or oral steroids with the possibility of a watchful expectancy and a calculated delay in the introduction of the DMARDs. But in childhood uveitis, especially those related to JIA, one should have an early introduction of DMARDs, with the drug of choices being methotrexate and adalimumab, as was discussed some time back. There are other agents also that are useful. But in pediatric uveitis, probably the 2 most important points are the zero tolerance issues. The zero tolerance issues involve zero tolerance towards inflammation, and even if the relapses are limited to the anterior segment, they mandate increase in immunomodulation. The other zero tolerance issue is for the requirement of oral steroids. One should see to it that DMARDs are at a level which is enough so that one is able to stop the oral steroids in pediatric uveitis. Now, treatment recommendation is there with DMARDs. They are associated with a reduced risk of developing uveitis, and corticosteroid intake in JSPA actually decreases the odds of developing uveitis. Among the conventional DMARDs, the methotrexate and sulfasalazine have been known to reduce the risk of uveitis onset. Of course, this data is a little older data. Now we have adalimumab. The fourth difference probably is with the use of NSAIDs. We use a lot of NSAIDs in adult uveitis. NSAIDs in JSPA do not decrease, but rather they increase the risk of developing uveitis. And this is an important fact because many patients with ERA who may present to a pediatrician, and the pediatrician may start NSAIDs. So NSAIDs in juvenile spondyloarthropathy are completely no-no. They actually increase the risk of developing uveitis, and therefore there is a requirement for consideration of the strategy among all treating clinicians. So what are the treatment recommendations for JSPA regarding biologics? It is this agent, etanercept, which given as monotherapy or in combination with methotrexate actually decreases the risk for uveitis manifestation. However, patient groups which have received these medications is very small. We have used this in a few patients in our practice and found it to be a very useful agent. The fifth difference comes to screening and follow-up. When it comes to screening or follow-up, the essential difference in patients with JIA or established childhood uveitis in JIA is the need for a very close follow-up, a 3 to 4 monthly follow-ups, even if the eye is silent and insidious. This is obvious because the eye is silent, the patient is not going to come forth with complaints of redness, pain, decrease of vision. Regarding screening and follow-up, there are 3 things that one should keep in mind. Children with JSPA, we think they are symptomatic with acute anterior uveitis and they would present with pain, light sensitivity and redness of eyes. Having said that, that would be the subtype where HLA-B27 positivity is about 38% and the ERA group has the highest rate of HLA-B27 positivity. So it is this ERA patients who would actually present with the redness, pain, decrease of vision. But the early onset JSPA, which is similar to oligoarthritic JIA, are the ones that present in a silent eye and therefore require a closer follow-up. So ophthalmology screening should occur every 3 months for children with JSPA and undifferentiated arthritis who are ANA positive and less than 7 years of age. Patients who are the older age group, they can be kept on a yearly follow-up. There are various screening protocols, the German protocol which recommends yearly examinations, the British guidelines which recommend a 3 to 4 monthly examination. In India, since ERA is the predominant population, we could have yearly examinations, but in the early onset, we should have a closer follow-up. With this, I would like to end the presentation and would be open to take any questions. Thank you.
Are there any questions here?
Just highlight few points regarding the epidemiology. Firstly, like if you see the Western literature, oligoarticular GIA is the first common cause, and then polyarticular GIA is the most common cause. But in India, ERA is the most common cause of GIA. So, but the ERA that we see don't present with much of chronic anterior uveitis. As they grow older, maybe one or few cases may be there, but as they grow older. But in India, it's mostly the polyarticular GIA and the juvenile PSA, which presents mostly with uveitis. And in the adult phase, they come with acute anterior uveitis. That is number one. Secondly, you mentioned about steroids. So this, you mean oral steroids are contraindicated in, increases the risk of uveitis, or is the topic, sorry, NSAIDs? You mean to say?
Oral NSAIDs.
Oral
NSAIDs.
But we,
so
we use a lot of oral, but we don't see, from a rheumatologist perspective, we don't see that much of uveitis in ERA patients.
So what I meant was that when these children have uveitis, the ophthalmologist should not resort to oral NSAIDs for treatment of these uveitis. So when these children will have uveitis, it is better to resort to DMARDs.
Yeah. But we, anyway, from the rheumatology side, we will be increasing. So that can also cause increase in risk of uveitis then?
No. That wouldn't be. That wouldn't be.
And the third thing is regarding the use of biologics. So we don't use etanercept much for uveitis. It's adalimumab, infliximab or golimumab. Rather, etanercept is, we say, contraindicated in uveitis.
Yeah. So that is something that we have been talking with our pediatric rheumatologists. We have had a patient or two where the uveitis and the knee joint pain wasn't getting controlled even with adalimumab, in which we've added etanercept and we found a good response. So per se, that drug seems to be the one which maybe the rescue drug when you have already used methotrexate and adalimumab and still not getting response.
But there are other agents like infliximab or golimumab. So, like of the agents, we would first switch to the other, like infliximab or golimumab before. If you ask a rheumatologist, mostly etanercept is the last one. But there are cases where we have used etanercept or even secukinumab in the acute uveitis along with methotrexate.
Yeah. In fact, we've even among the new drugs, we've even tried tofacitinib in children, and even that gives a good response if used as an added agent to methotrexate.
We have been using a lot of tofacitinib even without methotrexate and I think Dr. Ramana's baricitinib trial will be coming very soon. Within the next 6 months, the baricitinib trial will come.
Thank you.
Thank you so much, Dr. Mayur. Please take your seat. With that, we come to our last presentation today. Dr. Peter McCluskey will be presenting 5 scleritis surprises. Welcome, sir.
Great. Thanks very much, everyone, and thanks to the organising committee for inviting me to be part of this uveitis subspecialty day. So I was asked to talk about 5 scleritis surprises, and these are the 5 things that I'm going to talk about: the classification, epidemiology, the associations, and the treatment. But I think the most the unexpected surprise is that there's been a real resurgence in research interest in scleritis around the world. There's many more groups now looking at their local results and the causes of scleritis, which is a really good thing. So Mr. Watson's classification really began close to 50 years ago, and it's one of the few disease classifications in ophthalmology that's really stood the test of time. I still use this same classification today as Mr. Watson taught me when I was his fellow. It is easy, it's clinical, it's anatomical, and it grades the severity of the inflammation, and dividing it between non-necrotizing and necrotizing, anterior and posterior, really helps you to sort out the likelier causes and how intense your treatment needs to be. This is an important paper that I'm just going to very briefly discuss on the epidemiology of scleritis, and it's sort of based on the really good computerized records that the NHS has. And this group from Moorfields went back and looked at 11 million patient visits to GPs over close to 20 years, and found that there were just over 3,000 cases where the diagnosis was scleritis, and they just looked at what's happened over that 20-year period. They couldn't really, because of the nature of the data, look specifically at what diseases systemically were associated with scleritis. But I think there are a number of important points for us. The first is that the incidence is falling, and it's gone down by at least 25% over the past 20 years. The prevalence is low. It's a very rare disease. There's basically about 1 case in 4 or 5 in 10,000 people. So it is a rare disease. Commoner in females, and being a female is actually a risk factor that was identified for developing scleritis. Non-Caucasian races have a higher incidence, and older patients or older individuals have a higher risk of developing scleritis. I think the most interesting things were that this study's confirmed a couple of things that we always were suspicious of, that patients who develop scleritis very commonly have been diagnosed already with some sort of inflammatory disorder, and that increases your risk of developing scleritis by a factor of 5 if you've already got a systemic autoimmune disease. And if you present with scleritis, you've got at least 2 times as higher risk of later on developing an inflammatory disorder. And the diseases that they found most commonly, the 3 commonest were GPA, Behçet's, and Sjogren's syndrome. But other important diseases were rheumatoid arthritis, lupus, inflammatory bowel disease, reactive disease, and sarcoidosis. And that really fits in with pretty close to our current sort of understanding of the common diseases that are associated with scleritis. Those being rheumatoid arthritis, anchor-associated vasculitis like GPA, seronegative arthritis, all forms of systemic vasculitis, inflammatory bowel disease, and sarcoidosis. And this is a sort of a fairly worldwide common group of associated systemic diseases. We also know that the more severe the scleritis, the more likely you are to have an associated systemic disease. In the same way that the older you are, the more likely you are to have an associated systemic disease. Necrotizing scleritis in all series in the literature is the least frequent pattern or phenotype rather of scleritis that we identify, but it's the one that's most commonly associated with systemic disease. And again, the severity of the disease determines how much or the likely treatment that you're going to need. So diffuse and nodular scleritis, you'll often get by with either oral steroids or an oral NSAID. But once you've got significant posterior scleritis, panscleritis or necrotizing scleritis, or as one of the earlier speakers talked about, PUK associated with scleritis rather than uveitis, you almost always need combination immunomodulatory therapy. And we also recognise that patients who we know have a systemic disease, it often signals a sort of a vasculitic phase of the illness, and they're much more likely to need IMT as well. So this is a sort of a reasonable algorithm for how to think about the treatment of scleritis. If it's anterior and non-necrotizing, you can either trial an oral NSAID or a course of oral prednisone, and it's likely that that will control the treatment in the disease in the majority of our patients. Some of these patients need a steroid-sparing agent. It's uncommon for them to need a biologic or long-term immunomodulatory therapy. Patients who can't take systemic therapy, this is where, as long as you've eliminated infection, subconjunctival steroids are very useful. Patients with necrotizing disease or posterior scleritis, they need combination immunotherapy, so high-dose oral steroids. Usually we'll start our patients on methotrexate, and because we can access biologics much more easily now, we'll accelerate to or escalate their treatment to a biologic fairly early. Although this paper's 40 years old now, it still emphasises a really important point, that necrotizing scleritis, if you don't treat it aggressively because of its risk of systemic vasculitis, there's a very high, up to 50% 5-year mortality rate without treatment. So necrotizing scleritis, in my clinic, we manage these patients in combination with a rheumatologist or immunologist. We actually have a rheumatologist who comes to our clinic every week, and the multidisciplinary team approach really is a very good way of managing these patients. As I said earlier, we start them on high-dose oral steroids. We'll add an additional immunosuppressive drug at the time we start them on steroids, or as soon as the workup's done, usually either methotrexate or mycophenolate. Rather now than adding tacrolimus or escalating to cyclophosphamide, if they don't respond well, we'll usually start with a TNF blocker, and if that doesn't work, go to a B-cell depleting agent like rituximab. The other important thing always to remember is about 10% of our patients with scleritis, it's caused by infection. In my country and in my city, the commonest sort of infection that we see is after pterygium surgery, where it's usually the Pseudomonas or some sort of a mold fungus. But it can follow trauma. Infective scleritis can be associated with systemic infections such as TB and syphilis. You can get severe scleritis after herpes zoster, and it can obviously spread contiguously from the cornea in patients with acanthamoeba and severe herpetic keratouveitis. And occasionally we also see patients who have severe intraocular inflammation who get a severe panscleritis as part of their disease. I've certainly seen that a couple of times now in herpetic retinitis and in patients with toxoplasmosis. Again, infectious scleritis, we really need to treat it aggressively. I'm lucky enough in our uveitis unit is that we have our own sort of on-call infectious diseases specialist that we can get to come to our clinic. She helps us treat our TB-related scleritis and pretty much all of our fungal and bacterial scleritises, and we use a combination of aggressive systemic therapy and high-dose topical and regional therapy, a low threshold for surgically exploring these patients to drain them, and several times now we've used this continuous subpalpebral infusion cannula of antibiotics to get on top of the infection. So, in summary, basically, Mr. Watson's classification is still very useful clinically, and it's stood the test of time. Scleritis, although a rare disease and in probably most parts of the world becoming less common, it's still a really important disease for us to recognise because of its frequent associations with sometimes potentially lethal systemic inflammatory disorders and quite commonly associated with infection. And particularly in TB endemic regions of the world, TB is something to always think about in causing scleritis. And the best thing is that we now have better treatment. We're starting to get towards precision management where we can use biologics that actually target the underlying pathology. So thanks very much for your attention.
Thank you so much, sir. Any interactions from the floor, please? Please take a seat, sir.
We've got a few moments for some discussion, and I think there's a couple of interesting things we could talk about. The first is, could I ask Dr. Choi, do you tap all of your patients with hypertensive anterior uveitis, or what are your criteria for wanting to do an AC tap in your patients?
It's very important in the decision of the clinics. So I do taps for the treatment of cytomegalovirus, especially because HSV1 does not need PCR positive results. So I tap in cases of IOP elevation very high, like more than 40 or 50, and also when the patients accompanies higher recurrence rate compared to other uveitis cases. And thirdly, and I do the tap when patient shows the decrease in cornea endothelial cell count.
Great. And I might ask both of our speakers who've spoken about pediatric uveitis, do you see much pediatric sarcoidosis in India, and do you see much Blau's syndrome in India?
Yeah, so we've been seeing quite a few patients of Blau syndrome. In fact, what I feel is that quite a bit of the difficult granulomatous uveitis in children, because they are not being tested, probably is the reason why we are missing them. We've been testing and we've found, in fact, I have around 4 to 5 children with Blau who are on follow-up. The difficulty with Blau is that they are very difficult to control inflammations. We've had patients in whom methotrexate alone hasn't been able to control inflammation. We've even combined a mycophenolate, and yet they would keep relapsing. In fact, one of our patients is on a triple immunomodulation, methotrexate, mycophenolate. We've added tofacitinib now. So I think Blau is one entity that probably we are not diagnosing too much because the genetic testing for it is a little difficult to have for availability and financial constraints. But I think it is more in the population than we think it is.
Yeah. What about sarcoid? Do you see much pediatric sarcoid?
Not much, not that much. But yes, in a focused uveitis practice like ours, we have patients, but I don't think there is so much of pediatric sarcoidosis. I don't know what Partho feels about this.
Okay. And I guess my other question would be, what do you do for the TNF poor responders, or people, patients who don't respond well to TNF blockers with pediatric uveitis?
So we've had some patients who haven't responded to infliximab. We've kept them on adalimumab, and of late we've started introducing tofacitinib. And like I said, etanercept was an agent that we've used for a patient who poorly responded to both infliximab and adalimumab. I think in that realm, it is better that we leave it to pediatric rheumatologists, because they will be able to combine these agents better.
Yeah.
I think it requires a combination of agents like adalimumab, perhaps with one of the other agents like tofacitinib and etanercept.
Yeah.
What would you feel?
We use methotrexate along with adalimumab, or methotrexate plus infliximab, or methotrexate plus golimumab.
Yeah.
Really, we would try to avoid etanercept. And regarding tofacitinib also is the same. Methotrexate, all these DMARDs, oral DMARDs combined with tofacitinib.
Yeah.
We generally won't combine a biologic DMARD with a small molecule inhibitor.
Yeah. But you guys are using JAK inhibitors now. Yeah.
Yeah, recently, I think we have published one series of tofacitinib in children, 10 children treated with Professor Ramanan. So what we have realized that this is our first line treatment was first methotrexate, and then they responded, because in India it's difficult to shift them to adalimumab primarily because of the cost factor. So we tried the children with a combined immunosuppressive like oral methotrexate and mycophenolate for quite a long time, and when they are not responding to that, then we shifted this patient to tofacitinib, and our response was good, but only 10 children. And coming, I'm sorry I missed this question, but the pediatric, I feel there is a significant overlapping in India, maybe in, I don't know about the other country, between the pediatric sarcoidosis and Blau syndrome, because many a time we suspect, and the diagnosis is not always possible, Blaus, and they come very late also.
Yeah.
So
I agree. I'm sure we've missed quite a few in my city, and I guess clinically the only clue we found that's useful is the Blaus kids not uncommonly have a family history, and secondly they often have a skin rash that's where it starts, whereas the sarcoid kids just have polyarthritis and uveitis. But I think a challenging area. Okay, that's my questions. How are we doing? Yeah. I think, it's actually, we've just nicely filled our session. So thank you very much to all the speakers and to my co-chairs, and thank you to the audience for coming along. It's been a really interesting session. Thanks very much, everyone.
Thank you, sir. Thank you, everyone.